She had passed the cognitive screening at her annual physical 14 months earlier. Not barely passed, scored well. Her physician noted her memory as sharp and her reasoning as intact. She left that appointment without concern, without follow-up, without any reason to think the conversation about cognition would come up again for years. 11 months later, her daughter called her 3 times before she answered, heard something in her mother's voice that she could not name, drove over and found her sitting at the kitchen table, unable to explain what day it was or what she had eaten for breakfast. The decline that took her from that clean cognitive screening to that kitchen table had happened in less than a year. What the family wanted to know, and what took months of medical review to surface, was not whether something had gone wrong. Clearly something had. What they wanted to know was when it had started and whether anything had caused it. The answer, when it arrived, was specific. The culprit was not a stroke, not a tumor, not the early arrival of a disease they had been bracing for. It was a medication she had been taking for 8 months for a condition entirely unrelated to her brain, a medication that appeared on no warning label she had ever read, a medication that her prescribing physician had not connected to cognitive function because the connection is not part of standard prescribing conversation for that drug class. That answer did not make the situation better, but it made it legible. It gave the family something to work with. It gave the physician something to examine, and in her case, something to change. What I want to walk you through today is the mechanism behind drug-induced cognitive decline, how it differs from progressive neurodegeneration, why it is so frequently missed in standard care, and the 9 specific medication classes most consistently associated with it in adults over 60. Not as a reason to stop taking medication, as a reason to have a conversation with your physician that the standard appointment structure is not designed to open. If you are over 60 and take any regular medication, stay with me through the mechanism first. The second half, where the 9 classes are named and explained, will make more sense once you understand what these drugs are doing inside the aging brain and why the aging brain is specifically vulnerable to it in a way a younger brain is not. Everything here is educational. It is not a replacement for direct conversation with your prescribing physician about your specific medications, your specific cognitive history, and whether the pattern in this video applies to your situation. That conversation is the point of this video, not a substitute for it. The aging brain is not simply a slower brain. It is a brain operating with reduced reserves across multiple systems simultaneously, and those reductions create specific vulnerabilities to drug effects that are entirely absent in younger adults on the identical medication at the identical dose. The first is the blood-brain barrier. This is the selective filtering system controlling what passes from the bloodstream into brain tissue. In younger adults, it is highly selective. In adults over 60, the tight junction proteins that create its selectivity loosen measurably. Substances that could not cross into brain tissue at 40 may cross more easily at 70, not because the drug changed, but because the barrier keeping it out has become less effective. The second is the cholinergic system. Acetylcholine is the primary neurotransmitter of memory formation, attention, and executive function. What most people are never told is that the cholinergic system declines with normal aging independently of any disease. By 65, most adults have measurably lower cholinergic transmission than they did at 40. Any additional burden on that system arrives on a reserve that is already reduced. The third is pharmacokinetic change. Liver enzymes break down medications more slowly with age. Kidney clearance of drug metabolites is reduced since kidney function declines by approximately 1% per year after 40. Body composition shifts toward more fat and less muscle, changing how lipid-soluble drugs distribute. A standard adult dose may produce significantly higher blood concentrations in a 70-year-old, sustained for significantly longer than the prescribing calculations assumed. That is the landscape every medication on this list enters when prescribed to an adult over 60. The first class is anticholinergic medications. This is the category with the longest and most established research record on cognitive risk, and it is also the category most people have never heard of because the word anticholinergic does not appear on most prescription labels or patient information sheets. Anticholinergic means the drug blocks acetylcholine receptors. It does so deliberately in many cases because blocking those receptors in specific peripheral tissues produces the therapeutic effect the medication is prescribed for. Bladder medications like oxybutynin and tolterodine block acetylcholine receptors in the bladder wall to reduce urgency and frequency. Antihistamines like diphenhydramine, the active ingredient in most over-the-counter sleep aids and allergy medications, block acetylcholine in the brain as part of their mechanism. Tricyclic antidepressants, some anti-nausea medications, and certain drugs for overactive bowel all carry significant anticholinergic activity. The problem is that the receptor those medications are blocking peripherally is the same receptor that supports memory and cognition centrally. And the aging brain, already operating on a cholinergic deficit, experiences an additional imposed deficit from the drug. Research published in JAMA Internal Medicine in 2015 by Gray and colleagues followed nearly 3,000 adults over 65 for 7 years and found that cumulative anticholinergic drug use was associated with significantly increased dementia risk, with the association growing stronger the higher the cumulative exposure. A follow-up analysis confirmed the association was strongest for medications taken daily for more than 3 years. The clinical language for what these drugs produce acutely is delirium. Confusion, disorientation, memory failure, and behavioral change appearing over hours to days in response to a new medication or dose increase. In younger adults, delirium is recognized as a medical emergency. In older adults, it is frequently misread as the arrival or acceleration of dementia because the presentation is identical and the background expectation that cognitive decline is happening anyway creates a diagnostic filter that screens out the simpler explanation. The second class is benzodiazepines. These are prescribed primarily for anxiety, insomnia, and muscle spasm. The commonly recognized names include diazepam, lorazepam, alprazolam, and clonazepam. They work by enhancing the effect of GABA, the brain's primary inhibitory neurotransmitter, producing sedation, anxiety reduction, and muscle relaxation. In older adults, benzodiazepines produce all of those intended effects and several unintended ones. The sedation that is therapeutic at a standard dose in a 40-year-old translates to oversedation, cognitive blunting, and impaired memory consolidation in a 70-year-old whose brain clears the drug substantially more slowly. A dose prescribed for nighttime sleep may still be producing active pharmacological effects at 9 in the morning because the metabolism that should have cleared it overnight did not complete the work. Research published in the BMJ in 2014 by Biliotti, Degage, and colleagues in a study following over 9,000 older adults found that benzodiazepine use was associated with a significantly increased risk of Alzheimer's disease diagnosis, with longer duration and higher cumulative dose associated with higher risk. The researchers specifically noted that the association could not be fully explained by indication, meaning the anxiety or insomnia being treated could not account for all of the elevated risk. The practical issue is that benzodiazepines prescribed acutely for a defined event, a surgery, a bereavement, a period of acute anxiety, frequently persist without formal reassessment. The acute event resolves, the prescription continues. Months and years of chronic daily benzodiazepine use accumulate in patients for whom the original clinical rationale has long since resolved. This is among the most common medication patterns in older adults identified in medication reconciliation reviews. The third class is proton pump inhibitors, or PPIs. These are among the most widely prescribed medications in the world and among the least suspected in conversations about cognitive risk. They include omeprazole, esomeprazole, lansoprazole, and pantoprazole, prescribed for acid reflux, gastroesophageal reflux disease, and gastric ulcer protection. The proposed mechanism connecting PPI use to cognitive risk involves vitamin B12 and magnesium. PPIs reduce gastric acid production, and gastric acid is required for the absorption of vitamin B12 from food. Long-term PPI use consistently produces measurable B12 decline in a significant proportion of users. Vitamin B12 deficiency causes neurological damage through a well-established pathway, producing demyelination of nerve fibers and progressive cognitive and neurological symptoms that in their early stages are clinically indistinguishable from other forms of dementia. A study published in JAMA Neurology in 2016 found that regular PPI use was associated with a significantly increased risk of dementia diagnosis compared with non-use, with the association holding after adjustment for multiple confounders. The researchers noted the finding required further investigation to establish causality, and that remains the state of the evidence. The association is consistent across multiple datasets. The mechanism is biologically plausible. The causal link has not been confirmed through randomized trial. What is confirmed is that long-term PPI use frequently produces B12 decline that goes undetected because B12 is not routinely monitored in PPI users, and early B12 deficiency produces symptoms that are easy to attribute to aging. The fourth class is sleep medications beyond benzodiazepines. The non-benzodiazepine sleep medications, zolpidem, zaloplan, and azopiclone, known informally as Z-drugs, were introduced partly on the premise that they were safer than benzodiazepines for older adults. The research on their cognitive effects has not supported that premise. They work on overlapping receptor systems, produce overlapping cognitive impairment, and in older adults carry the same problem of slower clearance, producing next-day sedation and memory impairment that persists well into waking hours. Diphenhydramine, mentioned under anticholinergics, bears specific repetition here because it is the active ingredient in most over-the-counter sleep products, including Benadryl, ZzzQuil, Unisom, and most store-brand sleep aids. Many older adults take these without considering them medications in the same category as prescriptions. They are available without prescription, they are widely familiar, and they are often used nightly for years. Their anticholinergic burden is substantial, and their cognitive effects in older adults are among the most clearly documented of any over-the-counter compound. The fifth class is certain antidepressants, particularly the older tricyclic antidepressants. The newer selective serotonin reuptake inhibitors, SSRIs, carry substantially lower anticholinergic burden and are generally better tolerated cognitively in older adults. The tricyclics, amitriptyline, nortriptyline, imipramine, carry significant anticholinergic activity that produces cognitive effects by the mechanism already described. They also persist in the body longer in older adults and produce sedation that compounds the cognitive impairment. The clinical complication is that depression itself impairs cognition, and the cognitive symptoms of depression in older adults, slowed processing, reduced memory retrieval, difficulty concentrating, can present in a way that is clinically indistinguishable from early dementia. A patient prescribed a tricyclic for depression may experience drug-induced cognitive worsening that is attributed to the depression or to emerging dementia rather than to the medication introduced to treat the depression. The sixth class is certain blood pressure medications, specifically beta blockers that cross the blood-brain barrier. Beta blockers are widely used and well established in cardiovascular management. Not all of them carry meaningful cognitive risk. The distinction is lipophilicity, the degree to which the drug dissolves in fat, which determines how readily it crosses into the brain. Propranolol and metoprolol are highly lipophilic and cross the blood-brain barrier extensively. Atenolol is more hydrophilic and crosses less readily. The cognitive effects associated with beta blockers, including slowed processing speed, memory difficulties, and depressive symptoms, are primarily documented with the lipophilic members of the class. This is a class where medication selection within the category matters as much as whether the category is used at all, and that distinction is available to any prescriber who is considering it. The seventh class is opioid pain medications. Opioids produce sedation, respiratory depression, and cognitive impairment through direct central nervous system effects. In older adults, the pharmacokinetic changes already described produce higher effective concentrations and slower clearance. Chronic opioid use is associated with measurable cognitive decline through multiple mechanisms, including direct neurochemical effects, sleep disruption, hormonal changes, and the neuroinflammatory effects of chronic opioid exposure documented in animal and some human research. The pain management context creates a specific challenge. Undertreated pain also impairs cognition and quality of life. The goal is not to eliminate opioid use where it is genuinely appropriate, but to ensure chronic opioid use in older adults includes explicit cognitive monitoring and regular reassessment of necessity. The eighth class is antihistamines used chronically for allergy management. The first-generation antihistamines, diphenhydramine and chlorpheniramine, cross the blood-brain barrier readily and carry substantial anticholinergic burden. The second-generation antihistamines, loratadine, cetirizine, fexofenadine, were designed specifically to minimize central penetration and carry substantially less cognitive risk. The distinction matters because many older adults managing chronic allergies remain on first-generation antihistamines by default or habit without awareness that alternatives with meaningfully different cognitive risk profiles exist and are equally available. The ninth class is corticosteroids used systemically at sustained doses. Short-course corticosteroids for acute inflammation carry temporary cognitive effects that resolve when the medication is stopped. Sustained systemic use at meaningful doses carries more concerning implications. Corticosteroids produce measurable effects on the hippocampus, the brain structure most central to memory formation, through glucocorticoid receptor activation, neuroinflammation, and suppression of neurogenesis. These effects are dose-dependent and duration-dependent. The question that matters most when you reach the end of this list is not whether any of these medications are on your own list. The question is whether any of them have been there long enough, at doses appropriate for your current physiology, that the risk profile may have shifted without a formal review. The medication reconciliation conversation, a formal review of every current medication, the original indication, whether that indication still applies, whether the dose is still appropriate for your current kidney function and body composition, and whether the cognitive risk profile has been explicitly weighed against the therapeutic benefit, is not a routine feature of standard quarterly appointments. It requires someone to initiate it explicitly. That is what I want you to take from this video. Not the 9 names, not the mechanism, the specific question to bring to the next appointment or to request a dedicated appointment to address. Has my complete medication list been formally reviewed in light of my age, my current kidney function, and my cognitive history? If you are over 65 and take more than 5 regular medications, that question is overdue for most of you. Research on polypharmacy in older adults consistently documents that a significant proportion of older adults are taking at least one medication that would not be recommended for their age group under current geriatric prescribing guidelines, and that the medication persists because the review that would surface it has not happened.